Jane Bridges back with Module 5. We're going to talk about prevention of complications. So let's talk about cardiovascular disease. Cardiovascular disease is a leading cause of death in our patients with diabetes. What are the causes? Heart attacks, strokes, and poor circulation in the legs. These complications relate to the big vessels in your body. It's called macrovascular disease. Now, there's a little aside I want to say. I was just reading an article from the UK that just announced that cardiovascular complications are no longer the leading cause of death in their patients in the UK. It's cancer. So it's interesting how we must be doing better with the management of cardiovascular disease such that our patients aren't dying of heart attacks and strokes. Unfortunately, they're getting cancer. So that'll be another avenue that eventually we'll all have to address in the future as we learn more about that. But now, back to cardiovascular disease. What do we do to prevent it? And again, this is going to become very repetitive. We control good and bad cholesterol, we lower blood pressure, we manage diabetes to the best of our ability, and we stop smoking. Smoking is an accelerant to all the complications of diabetes. So when you combine smoking on top of everything else, you can anticipate more earlier complications, including the premature disability and death I mentioned earlier. If you are a smoker, we would be happy to fill this quit now form out and send to the state of Indiana. I know the state of Illinois also has these forms. You send it to the state and they help you with your smoking cessation efforts. So bring this up with your primary care doctor. Say, hey, would you fill that form out and send it into the state? Because I would like some help and assistance and guidance with discontinuation of smoking. Let's talk about smoking stats, and I'm very particular about this. I don't want my patients smoking because when complications happen, they look to us to fix them, but a lot of time these complications are permanent and we can't reverse them. They're non-reversible. So let's talk about smoking in the state of Indiana. Over 1,100 Hoosiers die prematurely, there's that word again, each year from tobacco-related illnesses. 21% of Hoosiers smoke. That's about 1 out of 5. 7.6 billion in annual costs related to healthcare, lower productivity, and premature deaths, all from smoking. In Knox County, there are over 6,000 smokers out of a population of 38,000. There are 22 deaths from lung cancer, 1,115 deaths from cardiovascular disease each year, and there are 168 asthma-related ER visits each year. Indiana is the 41st worst state in our country in regards to smokers. This is nothing to be proud of. I can't encourage you all enough, if you are smokers, to please stop. Ask your doctor for help in that regards. Let's talk about high cholesterol. We also call this dyslipidemia. What should your cholesterol be? Cholesterol should be less than 200, triglycerides less than 150. The good cholesterol should be as high as possible, over 50 for women and over 40 for men. And LDL, which should be as low as possible, should be less than 100. And ideally, if you have heart disease of any form, strokes, heart attacks, poor circulation in your legs, the LDL should be around 70 or below. We use lots of medications to achieve those goals, from statins. You all are probably very familiar with Lipitor and Vytorin and Zocor and Pravastatin and Rosuvastatin or Crestor, just some names to throw out there. Fibric acids would be fenofibrate or Lopid or the old Gemfibrozil. We use ezetimibe, which is Zetia, as a power booster to these drugs. We can also use high-dose omega-3s. That drug is called Vascepa. And then there are injectables that we use to help lower lipids. Those are Praluent and Repatha. So we have lots of drugs in our formulary to help. It's just convincing patients to take them regularly. Now, if you ever get your lipid panel and you look at the triglycerides and the HDL, divide the triglycerides by your HDL number. And if that number is greater than 3, that means you have insulin resistance. Most likely, if you have type 2, it's going to be greater than 3. But it also means if it's greater than 3, you are at great risk for cardiovascular disease. All the more reason to control blood pressure, control the lipids, and to control your diabetes to reduce your risk of dying from cardiovascular disease. Now, a lot of patients get muscle cramps with statins, and that's why they frequently stop them. If you have mild muscle cramps, consider taking coenzyme Q10. This is a supplement you can buy over the counter at the drugstore, and I recommend 200 milligrams. And then make sure you drink a good glass of water before bedtime to, again, help reduce your risk of nighttime leg cramps. However, if the cramps become so severe and debilitating, please talk this over with your primary care provider or the person who prescribed those medicines to you. Now let's talk about high blood pressure. Your blood pressure should be done at every visit. Blood pressure should ideally be less than 140/90, but 130/80 is even better. So the lower the blood pressure, the better. We use lots of different drugs, but our first line drug for the management of high blood pressure are ACE inhibitors like lisinopril or ARBs like losartan, candesartan, irbesartan. These drugs not only lower blood pressure, but they offer kidney protection. The next step, we frequently like to add in a little bit of a diuretic like hydrochlorothiazide. We only go up to 25 milligrams a day. A little higher can cause blood sugars to rise, so we max it out at 25 milligrams a day. Patients with diabetes are a little bit more, can I say, fluffy. Your volume is a little bit bigger, and so if we give a little bit of water medicine, we tend to reduce blood volume and help reduce blood pressure. And then our next go-to are calcium channel blockers. For instance, like amlodipine is a real popular one. Now, those beta blockers I mentioned earlier that can mask your ability to sense low blood sugars are very helpful if you have heart disease. So your cardiologist or primary care doctor may prescribe them, especially if you have had a heart attack. So just be aware, you may not be able to sense a low and you need to check your blood sugars more often. Now let's talk about microvascular disease of the little tiny blood vessels, these little blood vessels you find in the back of your eyes or in your kidneys, or the little tiny blood vessels that wrap around the nerves throughout your body. You've probably heard these before. The microvascular disease affecting the eye is called retinopathy, nephropathy for kidney disease, neuropathy for nerve disease, and that includes peripheral and autonomic neuropathy, and I'll explain that here in a bit. Bones are affected. They fracture more. The brain is affected. We see more dementia as people age. The lung is affected with restrictive pulmonary disease, also known as fibrosis. So prevention of microvascular disease, again, comes about from keeping the blood sugars as near normal as possible, controlling blood pressure, controlling cholesterol, and not smoking. You're hearing that repetition. But again, all those things managed together help reduce your risk of complications from diabetes. Now let's dive a little deeper into retinopathy or diabetic eye disease. It is the leading cause of blindness in adults between the ages of 20 to 74. In addition to retinopathy, patients with diabetes get more glaucoma and more cataracts. To reduce your risk or slow the progression of eye disease, improve blood sugars, blood pressure, and lower lipids, triglycerides are notoriously hard on the eyes. Patients with type 1 diabetes will need a dilated eye exam. That is not the eye exam that you get at the Bureau of Motor Vehicles. This is an eye exam that you would get from your local eye doctor. So people with type 1 need their first eye exam within 5 years of their diagnosis, whereas patients with type 2 need a dilated eye exam around the time of diagnosis, because people with type 2 might have had diabetes for upwards of 7 years before diagnosis. Now, if there's no retinopathy on several consecutive eye exams, your eye doctor may say it's just fine to go out 2 years, and that is fine to do if all eye exams have been in good shape. So let's talk about diabetic kidney disease, also known as nephropathy. Diabetic kidney disease is the leading cause of end-stage renal disease requiring dialysis. So when we talk about end-stage, that means the kidneys are no longer functioning and the patient will now be kept alive via dialysis. To prevent or delay chronic kidney disease, again, we optimize blood sugar control, blood pressures, and lipids. Yearly, we test for protein in the urine, and we do blood tests like BUN and creatinine to follow your kidneys. Now, we use medications for blood pressure to help protect kidneys, like those ACEs and ARBs that I mentioned earlier. But now we have a really important new class of drugs in which the research has become more and more compelling about how these drugs can protect progression of renal disease. In fact, can prevent the occurrence of end-stage renal disease, the need to require dialysis, by 30 to 50%. So I'm predicting that in the future, this class of drugs will eventually become first line. When you're newly diagnosed with diabetes, we'll probably start these very, very early on to help protect your kidneys as well as your heart. This class of drugs I'm talking about are the SGLT2 inhibitors. That's Jardiance, Farxiga, Invokana, and Steglatro. Those are the 4 proprietary names of these drugs. So these drugs are going to help us reduce the risk of dialysis, which could be amazing because dialysis is so incredibly expensive and a huge healthcare cost to our nation. Now let's talk about diabetic nerve damage, also known as neuropathy. Symptoms: numbness, burning, tingling, sharp-shooting electrical pains. Typically, diabetic neuropathy is going to be bilateral, meaning both sides, both right and left feet and legs. And it's going to be very symmetrical. So if it's up to the ankles, it'll be up to the ankles on both sides. If it's up to the knees, it'll be up to the knees on both sides. Once it's up to the knees, it starts to affect the hands more. So if patients come in and they say, well, it's my diabetic neuropathy, it's my left leg. Well, not your right? No, it's just my left leg. That's not diabetic neuropathy. That's more than likely a problem with your back. So that's why I ask specifically where it's at. Where does it hurt? I'm looking for symmetry. If the symmetry's not there, there's asymmetry, then I'm going to be inquiring about what's going on with your back. A lot of these patients have significant, debilitating, horrific pain. And they go to doctors and they want medicines for that, and I get that. But they forget to treat the underlying cause of this problem, which is hyperglycemia or high sugars. So if you want to reduce the occurrence of pain, reduce these debilitating sensations down to maybe a nuisance once in a while, you improve your glycemic control to the best of your ability. You get that A1C down below 7 to help treat your nerves. It may take 6 months to a year for those nerves to heal, but they will get better and they'll be less problematic for you. In addition to all those unusual sensations, patients are frequently unbalanced. The nerves in your feet are not sending good sensations up to your brain about where your feet are planted on the earth, so you're very unsteady. Patients say, I walk like I'm drunk. You walk with a broad-based gait, and so you're at great risk for falling. That's why we ask patients who are starting to have more and more troubles with walking to use a cane. They need their hands and their eyes to help them balance. They will eventually progress to walkers. But I can't emphasize enough the importance of using these devices to prevent falls, because once you start falling, things start to change in your life. You will start to lose your independence and may end up in nursing homes because of bad falls. So even though it may be a bit of a blow to your ego to have to use a cane or a rollator to keep from falling, do it. Do whatever it takes to prevent falls. I can't emphasize this enough to you. Let's talk about the GI tract and how neuropathy affects that. We see a lot of constipation. We see vomiting, especially undigested food. That's called gastroparesis. And we see diarrhea, especially if it's nighttime diarrhea. Nocturnal diarrhea is frequently related to diabetic neuropathy. Patients experience bladder dysfunction. Their bladders don't empty, and they may leak a lot. And we send these patients to urology to get help and assistance with bladder dysfunction. And there's also sexual dysfunction in men and women. Patients may have excessive sweating. Now, you can sweat if you're on antidepressants, and frequently that's the number one cause of sweating in patients. But if you're not on antidepressants and you start to sweat when you eat spicy foods, in fact, it's profound. Water is just dripping off of them. That's called gustatory sweating, and that is a form of autonomic neuropathy. In contrast, patients may have very dry skin. Their skin may crack and peel, especially on their feet. And those cracks allow bacteria to enter that can lead to infections and can lead to unfortunate devastation to the feet. So keep your skin moisturized. Patients may have a neuropathy that affects the rhythm of the heart. We see a lot more atrial fibrillation, but if we see a persistent heart rate that's persistent, like at 105, and there's no variation in the heart rate, that certainly can tell us that that patient is at risk for cardiovascular disease. So we pay attention to heart rate variability. We also see precipitous drops in blood pressure such that the patient stands up and falls to the floor because the nervous system is not able to maintain a blood pressure upon standing. And this can be very devastating to people, leading to fractures. We see impingement neuropathy. That's carpal tunnel of the hand, and typically with carpal tunnel, you'll have numbness and pain in these middle fingers. Or you can have impingement of the ulnar nerve back here at the elbow, and these two fingers would have pain, numbness, and tingling. And if they become debilitating for the patients, we order nerve studies. And if the nerve studies indicate that the impingement is severe, we will offer you surgery to release the impingements so that you can be more comfortable and hopefully maintain the use of your hands. Because as patients progress with diabetes, they start to unfortunately lose fine motor skills. Some patients have troubles handling extremes of weather. They can't handle hot temperatures or cold, so they end up staying inside in controlled environments a lot more. So, diabetic neuropathy is a diagnosis of exclusion, however. I need to look for other causes before I just call it diabetes as a cause. I need to make sure that alcohol is not causing neuropathy, that you've not had chemotherapy in the past as a possible cause of neuropathy, that you do not have a low B12. And I mentioned how metformin impairs your stomach's ability to absorb B12. And so this can lead to neuropathy. Hypothyroidism can too. So there's lots of other reasons why you may have these symptoms. But if I don't find any other causes, then I will call it as I see it and call it diabetic neuropathy. So let's talk about foot care. Because of diabetic neuropathy in the feet and poor circulation, foot care is of such great importance. 1 out of 4 people with diabetes will experience a foot ulcer. That's huge. And about 15% of those ulcers will lead to amputation. And so that's why we want you to examine your feet every day. Now, if you can't see very well, your belly is too big to bend over, then you might want to put a non-breakable mirror on the floor and see if you can observe your feet that way. Or you have a family member or a loved one or a friend periodically look at your feet to make sure nothing is embedded in them, that there is no cause of concern for a possible deep callus or an ulcer in your feet. Again, your feet should be checked at every doctor's visit. At the start of our new patient visits, we do a monofilament. This is a little tiny filament that we touch in certain points of the feet, and we document that. Unfortunately, because we are so busy, we only get to do that at your initial visit, but it doesn't change what I'm going to do for you, which is always look at those feet, always manage your diabetes, control blood pressure, hypertension. It's not going to change what I'm going to do for you. It just might alert me that you just can't feel your feet, but most patients know when they can't feel their feet. Don't go barefoot. I can't tell you how many foreign objects are picked up by going barefoot in the home. Sewing needles, tacks, small children's toys can be embedded in feet. And so these can lead to devastating foot ulcerations. So please don't go barefoot in your home or outside for that matter. Keep your feet clean in between the toes because a lot of debris can accumulate here and deteriorate the skin in the webs of the toes. If you're going to lotion your feet, which is fine to do, lotion the outside of the feet, but none between the toes because this area can get pretty moist. And again, moisture will break the skin down. Protect your feet from extreme hot and cold, especially when you're at the beach. Please put sunscreen on your feet and wear sand shoes because hot sand can burn feet. That can lead to devastating outcomes as well. Now, we use our local podiatrists to help with trimming nails and calluses and dealing with foot deformities and ulcers. So if you do have a local podiatrist you want to see, that's great, but it won't matter. I'll always be looking at your feet when you come into my office. Let's talk about bone, joint, and connective tissue diseases. Patients with diabetes have more arthritis of the hips and knees. In fact, they get a lot of joint replacements. They have more spinal stenosis and cervical stenosis of their back, so they have back surgeries. I view a person with diabetes as having a very fragile musculoskeletal system. You know, you look at patients with diabetes and they may be overweight and obese, but the musculoskeletal system, I think, is fragile. And they seem to have so many orthopedic problems that keep them from being active and living quality lives. Because they fall more, they have more fractures, and again, they're more unbalanced. They may take medicines that cause them to fracture. They don't see as well, and they may not hear as well. In fact, we know people who do not hear well have a greater risk of falling because they turn to look at someone to read their lips, and they spin themselves around. They're already unbalanced, and so they spin themselves around and fall, leading to potential fractures. Patients with diabetes have more contractures of the hands and feet. In fact, you can test this to see if you have this. My hands are in a prayer sign, and this is normal. You cannot see between my fingers. But people with long-standing diabetes start to have contractures, and you can see through their hands. They may have Dupuytren's contractures here, so these two fingers may be drawn down. They may have fibrosis of these flexor tendons in the palms that can be painful and debilitating, leading to trigger fingers. So they have a lot of problems with their hands that make it difficult to draw up insulin and to give their shots or to check their sugars or to do fine motor movements that we do routinely in our daily lives. So their hands can be quite debilitated. They also get more frozen shoulders, and they can get frozen hips for that matter. And so frozen shoulders, they'll be like this. They'll try to lift their shoulder and they can't. And so we start in with physical therapy and exercises to try to loosen that shoulder. And if that still doesn't work, well, then the orthopedist will loosen that shoulder for you. And then unfortunately, when you get that one fixed, it'll go to the opposite side. So adhesive capsulitis or frozen shoulders can be very problematic for people with diabetes. And you don't appreciate what your shoulders do until you lose function of one of them. We see more rheumatoid arthritis as well. And of course, then we talked about the occurrence of foot ulcerations. So lots of bone, joint, and connective tissue diseases in our patients with diabetes. So that leads us to pain management. That's a tough situation for people with diabetes because they have pain. They have neuropathic pain from diabetic neuropathy, and they also have arthritic and joint pain. So we can prescribe nonsteroidals like Aleve and ibuprofen, but it can be hard on kidneys, especially on elders. And then we can use high-dose Tylenol or acetaminophen, but this can also be hard on kidneys and livers, especially with long-term use. We use anti-seizure medicines like gabapentin, also called Neurontin, and pregabalin, which is Lyrica, for neuropathic pain. These can work, however, they also have side effects. Patients on Neurontin tend to fall more because their legs just get a little bit more wobbly. They can be more sedated, or they can experience movements and jerks from these medicines. We use an antidepressant called duloxetine, also known as Cymbalta, for neuropathic pain. That helps depression as well as neuropathic pain, but there's side effects of that as well. So we always have to watch for side effects of drugs, and that's why I do such a routine review of systems, because I'm looking for those side effects. Narcotics like Lortabs, Percocets, Narco are strongly discouraged and not recommended for neuropathic pain. They may be used for orthopedic pain, but they're not very good for dealing with diabetic neuropathy. Now, a lot of my patients really dipped into CBD oil when it initially came out. It is a possible alternative for pain management. You need to follow the instructions on the vial. Typically, CBD oil is taken twice a day. Unfortunately, I don't think people were using big enough doses to make a difference in pain management. 30 to 60 milligrams per day is a pretty reasonable dose that might be beneficial for pain. Now, one of my resources said 1 to 6 milligrams per 10 pound of weight, but I guarantee you 6 milligrams per 10 pound of weight is a very, very high dose, and I wouldn't recommend going up that high. I think if you're going to use CBD oil, keep it around 30 to 60 milligrams per day. Now, patients are also prescribed steroids, and I've mentioned this before earlier, like prednisone. And it can be given orally or it can be injected right into the joints or muscle, and all this leads to hyperglycemia. Now, steroids can really help reduce pain, no doubt in my mind, but long-term steroids could pose a problem, and so we typically don't use them for very long. We give them to you, and then we let them taper off over time. Let's talk about oral health. Patients with diabetes may have more dental problems because their saliva is sweeter, leading to decay and deterioration of the teeth and gums. So brush your teeth twice a day and floss. Please see your dentist every 6 months. We want you to keep those teeth. When you have your teeth, you have better nutrition. When you have some teeth, you don't eat as well, you don't chew your food as well, and then you get into some digestive problems. And then when you have no teeth and no dentures, you start eating very, very soft foods that are higher in fat. And so that consequently could lead to some weight gain and nutrition issues. So please see your dentist. Do your best to maintain your teeth and also keep your dentures clean. Now let's talk about depression, and I'm sure after listening to all this, you might get depressed about hearing some of the complications of diabetes. But people with diabetes have a greater risk of experiencing symptoms of depression for a lot of different reasons. It's also called diabetes distress. Anyway, the daily demands of diabetes self-management can be problematic for a lot of people, doing it day in and day out, and I get that. It's hard, and we know that. Complications of diabetes can make patients very upset and depressed. They're starting to deal with an end-stage complication that they weren't anticipating, whether it be, going blind or dealing with kidney disease. They also experience poor health due to poor control. And again, that's where I'm going to come in and try to get those sugars under the best control possible to see if I can help them feel better physically, which may help them feel better emotionally. They have a lot of fears and frustrations in dealing with a chronic and expensive disease. Like, how am I going to pay for this? And this is really impacting my financial situation at home. And then besides dealing with diabetes, you've got family and work demands all together. And so we get that. It can be a great burden. You got to talk to us if there's a problem. We won't know unless you talk to us. I can ask, but many times patients say, oh yeah, I'm doing fine. I'm getting along fine. I get that you may not want to have that conversation with me at that moment in time, but maybe another healthcare provider might speak to your needs more in regards to this. I don't care who you talk to, but if you're struggling, talk to somebody. What are the signs and symptoms of depression? Loss of pleasure in activities that you once used to enjoy. That's called anhedonia. Weight gain or weight loss. You either have a good appetite or you're not eating at all. You can have a lot of loss of energy and fatigue. You just don't want to do anything. You're just so tired. You sleep too much or too little. And in fact, waking up in the middle of the night, which is called early morning awakening, is a hallmark of depression. You may have difficulties concentrating and making decisions. In fact, when I'm dealing with depressed patients, they can't even decide to take a medicine. So I offer it. I let them think about it. I write a note about it, and I say, you call me back if you would like to start something. So I give you a little time to think about it. Patients with depression may be very angry, short-fused, not very pleasant to be around. And again, that's when the patients are out of control. They behave in the same way. And family are pulling their hair out trying to interact with a patient who's very angry. You may have suicidal thoughts. We definitely need to know about that. And more importantly, I think people who are depressed just don't want to take care of themselves. So we see a lot of self-neglect, and that A1C will start to rise in relationship to their emotional well-being. Let's talk about immunizations. Annual flu vaccine every fall for everybody. Pneumonia vaccine is a series of 2 vaccines, Pneumovax 23 and Prevnar 13. You get these a year apart. It is recommended that patients with diabetes get hepatitis B vaccine. I don't promote this a lot, but that is a recommendation. And that's a series of 3. And I think one of the reasons why they recommend Hep B especially is because diabetes runs in families, and they're concerned that family members may share needles, lancets, insulin pens, things like that. And that's a great way of passing Hep B onto family members. You shouldn't do that anyway, but you shouldn't be sharing needles with anybody. Anyway, it is recommended, but I've not been diligent in promoting that, I must admit. I do recommend a shingles series. If you're of age, I recommend Shingrix. It is a series of 2 injections. And of course, I recommend a COVID series, whether it's 1 or 2 injections. Please do your due diligence, be a leader in your family, and get vaccinated for COVID. Now let's talk about sleep apnea. This seems to be a very prevalent problem in my practice. We always worry about sleep apnea when there's loud snoring, gasping, and choking episodes during sleep, witnessed lapses in breathing. In fact, your spouse may say, you know what, I was worried about whether you were going to start breathing or not. If that happens, we need to know about it because I bet you have apnea and we need to address it. Apnea leads to heart disease, hypertension, and obesity, because when you're sleep deprived at night, you want to console yourself during the day with eating more. So it's imperative that we help you sleep better at night and we treat sleep apnea. Other symptoms include restless sleep, morning headaches, excessive daytime sleepiness because you're trying to make up for what you didn't get at night, personality changes from sleep deprivation, erectile dysfunction, morning dry mouth, high blood pressure, being overweight, and having a collar size greater than 17 inches for men and greater than 16 inches for women. There may be more cognitive problems and depression. Again, that interruption of sleep leads to depression. There may be more perspiring at night while you sleep. And then frequent nighttime urination and even bedwetting in children can be related to sleep apnea. And again, when you get up to pee at night, it's because you're breathing on the way to the toilet. You're getting your oxygen levels back up. So your body wakes you up. You think you have to urinate. You go urinate and hopefully get your oxygen levels back up to normal range.